Absolutely. All right, we'll go ahead and get started. It's 12 o'clock. Welcome to Medical Grand Rounds. Very happy to see so many of you out here on a snowy Wednesday. So thanks for coming in person. We, of course, will broadcast these over Zoom all year long as well. A little bit of a teaser on March 1st. We're going to welcome Dr. Doug Corley from UCSF, speaking about getting to zero cancer deaths in colorectal cancer. And then on March 8th, we will actually be virtual. So I keep telling you to come here in person, but on March 8th, do not come here in person because we're going to be doing one of our quarterly systems improvement conferences led by Dr. Ansett and his team. As a reminder, all conferences are open for CME and MOC credit. Please use the QR code. Also use the QR code to nominate speakers for next year's Grand Round series, which we're planning actively. And questions today will come from our live audience as well as from the Q&A feature on Zoom. Thank you to the chief residents who are going to watch the Q&A feature for us. And now I really am pleased to welcome today's speaker, Dr. Joynt Maddox. Dr. Joynt Maddox is an associate professor of medicine at Washington University School of Medicine in St. Louis. She is the co-director of the Center for Health Economics and Policy through the Institute for Public Health at Washington University, and she's also the director for the Center of Health Services and Policy Research at WashU School of Medicine. She did her undergrad work at Princeton University, where she graduated with high honors and was a member of Phi Beta Kappa. Her medical school was at Duke University, where she received the Dean's Award and a really lovely award entitled the Ideal Physician Award, which I thought was great. I did go deep. She did her internship and residency also at Duke, where she was the chief medical resident, a fellow in cardiovascular medicine at the Brigham. She also did a research fellowship in health policy at the Harvard School of Public Health and has advanced training with an MPH in clinical effectiveness, also from the Harvard School of Public Health. She is an accomplished physician, health policy researcher, educator, whose work focuses on improving the quality and equity of healthcare in the United States. Related to her topic today, Dr. Joynt Maddox spent several years after her training in the trenches in Washington, D.C., where she was the senior advisor to the Deputy Assistant Secretary of Planning and Evaluation in the Office of Health Policy through the United States Department of Health and Human Services. Her work is incredibly well-funded and very diverse. She holds several R01s for which she is the PI or co-PI, several other R01s on which she is a lead investigator, and she's also the PI on a U01 award. And I want to read a few of those because I think they really speak to what she does. Those awards are entitled Improving the Quality of Care Provided Through Bundled Payments for Patients with Alzheimer's Disease and Other Forms of Dementia and Frailty, The Impact of Bundled Payments for Cardiopulmonary Disease in High-Risk Populations, Cardiovascular Health for Low-Income Working Age Adults in the U.S., Healthcare Access Policy and the Pandemic, Observational Stays and Readmissions for Older Adults, and then the U01 is on rural-urban disparities in the spillover effects from COVID-19. In addition to all of her work on public policy and health outcomes, she really is a renowned educator and a champion of diversity and equity in medicine. She was recently the Associate Program Director for Diversity, Equity, and Inclusion in the WashU Cardiovascular Fellowship Program, and she currently is the co-chair of the Washington University Anti-Racism Task Force. I can go on and on. I won't. But so I really want to welcome her today. She's a passionate advocate for improving healthcare and outcomes for all Americans. It really is a pleasure to welcome Dr. Joynt Maddox.
Thank you. That was very kind and a little embarrassing, but I appreciate it. Thank you all for having me. It's a real honor to be here. Terrific to see a lot of friendly faces and familiar faces in the audience and to get to spend some time with you this afternoon. So I'm going to try to cover the topic of health policy outcomes and equity, which we could talk about for 16 years, but we'll try to just go through some of the basics in about 45 minutes and leave some time for questions. Some of this will be review for a lot of you. Some of it I hope will be thought-provoking, but I hope that everyone sees a little bit of what they do in what I do and what I think about, and hope that it leads to some ongoing thoughts and hopefully collaborations. Okay, I apparently did not have my disclosure slide in here, but I do have grant funding, as mentioned, related to a lot of the payment models I'll talk about today. I do health policy advising for Centene Corporation and have received research funding from Humana. So this is what I'm going to cover. I'm going to start by talking briefly about health outcomes and health inequities, a very brief introduction to what is health policy, and then spend most of the time talking about how policy can positively impact outcomes and equity in health. Thinking about this as one of the pieces in our toolkit to go along with the pieces that all of you have in your toolkits to work toward a common mission. So as we all know, the US healthcare system produces high costs and poor outcomes. So this is a fascinating graph that if anyone is interested, you should go to the website and actually watch it in real time so it moves. And you can see as spending goes up on healthcare, you end up gaining an awful lot in terms of longevity. And then you sort of start to level out. And the US has taken this to a fantastic extreme and continued to spend with little to no gain in additional, at least longevity. So you can see our life expectancy versus health expenditure, we're way out there. But buried under that are deep, deep inequities. And part of the reason why we do perform that way is because of the unevenness of the way in which we've applied our advances in medicine over the last centuries. So there are persistent racial inequities in cardiovascular death. You can see here women on the left and then on the right, looking at Black compared to white patients in terms of age-adjusted population level mortality for cardiovascular disease. Some improvement in closing the gap and actually an overall mortality that has flattened out and has actually started to go back up in the wrong direction in the past few years. We see similar health inequities based on poverty. These are obviously modeled lines, so they're a little bit straighter, but you can see if you look at Medicare patients who also receive Medicaid, so dually enrolled individuals, you can see that we've not closed the gap in mortality over the past couple decades, despite people knowing about these inequities and actually doing a lot of work to try to reduce them. And perhaps the most widening inequity at present is that related to rural health. So you can see that through the mid-1980s, rural and urban death rates were about the same. And then over the past couple decades, as the urban population level death rate has continued to improve, the rural in the orange line there has stagnated and again has gone back up in the opposite direction related to the opioid epidemic along with other factors. And now there's almost a 20% difference in population level death rates for rural versus urban communities. We know that combining these risk factors compounds risk. So if you split out rural high poverty, that's the solid orange line with the most stagnation improvement in death rate, whereas urban low poverty is the dotted blue line at the bottom. And if you superimpose race onto this same graph, you would create a further set of sort of intersectional inequities. We also know that politics are now a risk factor with pretty systematic disinvestment in public health based on politics. And you can see a widening mortality gap between Republican and Democratic counties, even after accounting for other differences in those counties over time. And this includes cardiovascular mortality and cancer mortality as the ways that that mortality gap is widening the most. Unless you think that this is only rural, this is a terrible slide, I apologize. But even those top, I just have a pointer. Those top two lines there are rural, Republican and Democrat. And so at every level of rurality, there is still an effect of politics above and beyond rurality. Now, this is a map that has been reproduced many times over. Any of you in the audience who treat any individual condition, you can just put that condition into the same map and you will have the exact same parts of the country that have the worst outcomes. We see it for diabetes, obesity, and consequently cardiovascular disease. We see hypertension, cancer. Now, all these things may be tied together, and we'll talk about why that might be the case, but this has been the same map for quite some time, and we have not made progress on reducing these systemic inequities. So, what underlies these differences? As a good cardiologist, I should mention it's related to diet and exercise. I hope you're all eating healthy lunches out of those boxes. We know tobacco use, stress. We're learning about inflammation and the ways that that ties into all the diseases that we treat, environmental exposures. And we're starting to understand the power of poverty, of racism, of access to education, primary care, and specialty care in driving these deep inequities that we see across the country. But what these have in common is that they're fundamentally structural. There are no babies born in this country who wish to grow up unhealthy, right? Who wish to be in a place without access, who wish to live a life full of stress and inflammation and lack of opportunity. So health inequities and poor health outcomes are, in my opinion, and I hope yours by the end of this session, a policy problem. They're reflective of systemic, broad, and longstanding issues, and they're not gonna go away by clinician will alone, or by the invention of a new drug or a new device or new surgical technique or new imaging modality. Those are super important things and we should develop all of them, but they are not fundamentally going to undo health inequities. We have to structurally undo what was structurally done if we want to see differences in the outcomes that we achieve. So what is health policy? So health policy are the federal, state, and local statutes and regulations that basically determine the rules of the game. So statute is law, and only Congress or the sort of equivalent, state bodies can pass laws. So the Affordable Care Act is a law. It established Medicaid expansion, established a bunch of other value-based payment programs. It can't go away. CMS has to do it, right? We can't just decide as a group that something that's in law is a bad idea and not do it anymore. It has to be done away by a different law. So that's a pretty high bar, and it's why change is so slow in policy, because these are literally written into law. On the other hand, regulation is the details of implementation. So things that are done by agencies like Medicare. So payment rates for a stroke hospitalization in Medicare don't require legislative approval every year, which is good because we would never get anything done. If you think about something like the pandemic, it was really a mix of executive orders, legislative action, and a lot of agency action, FDA, CDC, CMS, that could work within their sort of regulatory capacity. And if you take that down to the state level, there's all sorts of levels of influence of policy between, counties and cities and all those sorts of things. So policy is a complicated landscape. It doesn't always require legislation, but it always requires some level of power and control, which is sort of why we landed in this situation. So I'm going to talk about 3 key areas of policy that impact health. There are certainly more, but I'm going to talk about coverage and access policy, which is sort of the starting point, right? Determining what you have access to. Payment and care delivery policy, which is if you do have access, what are you getting? And then social and economic policy, which is arguably the most important piece of this, but the part about which I am least qualified to talk. So I will leave that for the end. So coverage and access policy, we're going to start with. And we're going to start with the fact that minoritized, low-income, and rural communities lack coverage and access. We'll talk a little bit about what that looks like, and then about some of the solutions that have been positive and how we might take those to the next level. So we know there are major inequities in insurance coverage. And you can see here, moving along the screen, you've got men and women ages 45 to 54, 55 to 64, and 65 and up. The blue lines are the white population, the tan lines are the Hispanic population, and the orange lines are the Black population. And you can see that particularly in the young age groups, there are marked racial and ethnic disparities in insurance coverage. With, for example, Hispanic men ages 45 to 54, around 30% uninsurance rates. Now, you might notice 2 important things on this graph. One is that the lines on the right do not look like the lines in the middle on the left, and that's Medicare. So once people hit 65, we have decided that they deserve access to healthcare, and that's what they get. And there are some racial and ethnic inequities. There are some issues around how long you've worked in the system. So for immigration, it's a big issue. But by and large, people are covered over the age of 65, and there are markedly lower inequities, at least in terms of coverage there. So we're going to spend our time thinking about the people that are in the left and middle boxes. So the other thing you might notice here is that the line goes along pretty straight and then dips a lot, right? So there was a big change. That was a policy change. That was the Affordable Care Act. So about 2/3 of the gain in coverage in that time was Medicaid, which we'll talk about. The rest was exchanges, which I'm not going to spend much time talking about. It like falls into the very policy wonky part of stuff, which I love talking about, but sells a little less well to a broad crowd. Essentially establishing an individual market that people could actually buy insurance from, which didn't exist before the ACA. So a quick reminder on Medicaid. So Medicaid is a state-administered program to provide health coverage to people living in poverty. It was created in 1965. And if anyone's into thought experiments, you could do the thought experiment about when we created Medicare and Medicaid at the same time, if we had created one program instead of 2 programs, because of differences in how people thought about who deserved what a different state of affairs we would be in right now. And that was actually on the table, and it was, fought by various groups. Not the least of which has been doctors over time, to be clear. But anyways, it is funded about 60-40 federal state, but match rates range. So New York pays about 50% of their Medicaid. Mississippi pays 24% of their Medicaid. So it varies by state how much of the bill they have to pick up. It covers, I should actually update this, more than 76 million beneficiaries, half of all births, and 60% of nursing home care. So Medicaid is a big deal. And if you look at the graph on the right, you can see that the yellow bar down at the bottom of enrollees is what's considered the aged group. And those are folks who are over 65 who are also enrolled in Medicaid, and they account for more than 20% of spending, despite making up about 9% of enrollees. And that's because Medicare doesn't cover nursing home care. So we fund most of long-term care in this country through that. The red bar that is also vastly overrepresented in spending is individuals with disabilities. So the children and working age adults make up the majority of the enrollees. They really aren't responsible for any of the big ticket items. That said, Medicaid eligibility is always a fight, and it differs quite a bit by state. So all states cover pregnant women and most children up to 200 to 300% of FPL, which is about $12,000 for an individual. Medicaid expansion under the ACA gave states the option to get an enhanced match, so fully covered Medicaid to start, if they expanded Medicaid to people under 138% of poverty. So in 2018, which I've included because I live in Missouri and that's the before times for us, in order to qualify for Medicaid in Missouri, you had to be an adult with dependent children making less than 22% of the federal poverty limit. That is not very much money. And if you think with that much money that you could afford insurance on the private market, like I have a bridge to sell you, there is no way. And so essentially, if you were living in poverty in a non-expansion state, you did not have access to insurance coverage. If you were an adult without a dependent child, you could not get Medicaid. There was just no, you could go, but there's no way to sign up. In the expansion states, which are the orangish yellow bars at the bottom, in either group, you qualify up to 138% poverty. And between 100, and there's some strange policy things that happen with ACA, but between 138% and then scaling up is where you get subsidies to buy on the exchange. So in expansion states, there's a reasonable, though very patchworky way to get coverage to people. Medicaid expansion as of February 2023 looks like this. You don't have to squint to see a little bit of a geographic predilection for electing to expand Medicaid. North Carolina passed it through their House quite recently. So we'll see where that goes. And South Dakota had a popular vote. So we'll see where that goes. So there may be 2 more states added in 2023. Consequently, coverage remains pretty uneven across states. Texas has actually probably higher now, but close to 20% uninsurance rate. My current state of Missouri is sort of in the middle, and then Colorado is in the lower middle down there at about 8% or so. Massachusetts, which expanded under Romney Care before everybody else did, is all the way down at the bottom, closer to 3% uninsured. So why does this matter? It does not matter for insurance itself. It matters because insurance matters. So there's unequivocal evidence for financial protection of individuals and hospitals with Medicaid expansion. So particularly for rural hospitals, hospitals stay open when they can get paid. And when you are a rural hospital with a very vulnerable patient base, you cannot survive in this day and age without Medicaid expansion. So closures have been very different in expansion states and non-expansion states. There's strong evidence for greater access to primary care, more ambulatory care visits, prescription meds, adherence, preventive services. All that evidence is building and is pretty strong at this point. There's moderate evidence for better self-reported health. And actually the mental health starts right away. It is so stressful to be uninsured that people actually have a mental health benefit before they have received any mental health services, which is kind of interesting. There's mixed evidence for utilization. People actually use more healthcare when they have insurance. It doesn't seem wrong necessarily. We've all probably had the experience of seeing someone come in with a mass or something that you wish they would have gotten taken care of a lot earlier. So we want people to use healthcare, and they do. There's pent-up need, there's unmet need. There's moderate evidence for lower mortality, including infant mortality, which I'd argue is the most important mortality against which we should work, as well as cardiovascular and cancer mortality. And the impacts are clearly largest for minoritized groups and in rural areas where there has been the most need previously. There's an interesting coming cliff to think about with a public health emergency. So during the public health emergency, you couldn't kick somebody off Medicaid. And many Medicaid agencies have been aggressively in the business of kicking people off Medicaid, right? I mean, people cycle on and off jobs. So some of it is because people become eligible and ineligible. Some of it is just because they want to save money. So this is our center tracker for Medicaid expansion in Missouri. And the purple is our expansion population. But you can see before the purple, there's I don't know, 300,000 extra people on Medicaid that would not have been there previously, just because the state wasn't allowed to kick people off. A high proportion of those people actually still qualify for Medicaid, but they get kicked off for sort of procedural reasons. As soon as the public health emergency ends, which will be in May, states can start reassessing eligibility, which is code for kicking people off Medicaid. Some people won't qualify anymore. Some will and will fall off for procedural reasons. And it is going to be a big deal for hospitals and health systems, and most importantly for patients. So that's something to watch in Medicaid this year. So there are other barriers to access beyond insurance. So it also matters, can you pay for your care? Can you find care? And we know that there are pretty profound differences by race and ethnicity in terms of other access issues beyond insurance. So this is some survey data looking at the proportion of folks who didn't see a doctor due to cost, who delayed care due to other reasons, or who lacked a usual source of care when sick other than the emergency room. And you can see that there's differences with racially and ethnically minoritized groups much more likely to have access challenges. And of course, we know there's major barriers to access by rurality. This is just some work by some trainees of mine, which I always like to show, demonstrating a lack of access to specialist care in rural areas compared to metropolitan areas in the dark blue bars compared to the gray bars. There's actually pretty equivalent access to primary care in rural areas now, but specialist care is way behind. And the more specialized, the more behind. And then if you look at any high-tech procedure, so we just looked at hypothermia, therapeutic hypothermia back when we were pretty sure that was the right thing to do, which it may or may not be, but be that as it may, you can see that the entire middle of the country, there's usually less than 10, and in some cases less than 5% of hospitals that have that technology, a guideline recommended therapy for patients with cardiac arrest. Okay, so that's coverage and access, and you can imagine all the ways in which we could potentially use some policy levers to make that better. Let's now talk about what people get when they get their access. So we'll talk about payment and care delivery policy. So we know that there's inadequate quality of care and that that's worse in under-resourced areas. Particularly, we're going to talk about safety net and rural hospitals. Now, the reasons for this are very complex, and it is, I don't know, it's like a human thing that it's hard to hold nuance in your head, right? Like it's hard to have more than one thought at the same time. But this is an area in which there are so many things going on at the same time. You have to hold more than one thought at your head at the same time. So the reasons that patient outcomes are worse at under-resourced hospitals are many. They have fewer resources. They have sicker patients. And it is much harder to attract and retain staff, right? The staff turnover is higher, training is less adequate, working conditions are tougher, there's less ancillary support, and consequently, there's lower quality of care. And you can imagine thinking about this with schools, right? So the schools that have the least resource are often the ones that are asked to do the hardest job. And that's sort of the same in hospitals. We're a service industry too. People are not widgets. We get who we get. They bring with them a whole lot of things when they walk in the emergency department door, the clinic door. And if they're bringing a complex set of social or medical challenges to a place with fewer resources, where it's harder to get staff, where there's worse working conditions and less ancillary support, it's a recipe for worse health outcomes. So we know, for example, optimal stroke treatment is less often delivered in rural areas. This is rates of thrombolytics and endovascular therapy from 2012 through 2017. And you can see, particularly for EVT, even though you can see a clear upward trend, persistent gaps between urban and rural patients in access to care. We know that there are inequities beyond quality. So we know patients living in poverty are more likely to be readmitted. Some of this may be because of worse treatment. Some of it is almost certainly because of challenges faced outside the hospital walls. This is a study of young adults, so Medicaid or privately insured, almost double the readmission rates. And this is coming from 2007, so this is not a new problem. Anemia, diabetes, chronic lung disease, substance abuse, mental illness, we see markedly higher readmission rates in individuals who are living in poverty, even independent of the quality of care they receive, given that they do actually also receive lower quality care, right? So both are true at the same time. Now this is a regression model about which I apologize. There's no equation. I find it really distasteful to put equations in talks, but these are all the odds ratios associated with a number of items that go into the CMS risk adjustment model for readmission, I think for heart attack. It's been a while. And there are a lot of things on here that make some sense. Have you had a cabbage? Do you have valvular heart disease, et cetera? But if you look at the top, we threw one additional factor into this model, keeping everything else the same: poverty. Simply, was someone also enrolled in Medicaid? They were on Medicare. Were they duly enrolled in Medicaid? And it came out as the 5th most powerful predictor of readmission. It's behind hematological, which is a bit of a grab bag, I'll give you that, COPD, ESRD on dialysis, iron deficiency anemia, but ahead of metastatic cancer, end-stage liver disease, and stroke. This is a powerful, powerful risk factor. And much like these other ones, it is not something that we can fix in one visit. So if you think that anything you do in a hospital visit can overcome 60 years of lived experience with racism or poverty, you do not understand social determinants. That's not how it works. And we don't think that about renal failure, right? That we can give somebody the magic pill and fix their renal failure. That's why we risk adjust for it. It is the same thing for social determinants. They are life course, they are powerful, and they are difficult to treat. And ignoring them is not a way that we're going to make any of this better, but these are real. So we also know, I referred to race being associated with higher readmission rates as well. We know that Black and Hispanic patients are more likely to be readmitted for acute MI, CHF, and pneumonia. And we know that racism is the root of this, right? It is not race. It is a lived experience of racism that's led to egregious health inequities. And there are profound structural barriers that are built into the systems in which we work every day. There is a historical disinvestment that has led to a lack of access to healthcare and treatment within healthcare, substandard education, housing, jobs, and treatment by the criminal justice system. And that those things don't just play out on the news, they play out in people's bodies. So you can actually measure the physiologic impacts of racism and discrimination in something called allostatic load. There's a number of sort of emerging studies in this area. And in a study that was published not long ago, you can see, for example, that the associated with a pervasive discrimination score, you can see a reflection of that in the allostatic load, which is sort of a physiologic measure for white individuals or for African Americans. Now, in our society, one of those groups experiences a heck of a lot more discrimination than the other, but there's not something unique about the race. It's about the experience of the racism. And if we don't name that, we're not going to come up with solutions that try to get around it. So now to turn and put my policy hat on for a moment, when the government was thinking about how they should improve this readmissions problem specifically, but you could take this for pretty much any issue in the quality of healthcare, they created something called the Hospital Readmissions Reduction Program. It's a penalty program for hospitals with excess readmissions, and hospitals are evaluated on acute MI, CHF, pneumonia, COPD, hips and knees, and CABG, but penalties are levied on all admissions. So if any of you do, I don't know, lung transplants, you get paid less based on how we perform in our readmissions for acute MI, CHF, and pneumonia, and now a few other conditions. This program is currently penalizing 80% or more of US hospitals, and it has a cap at 3% of base DRG payments, which is a meaningful amount of money. I know it's been a bit of an odd year for hospital margins over the past couple of years, but most hospitals do not, at least for a long time, operate with margins much above that. And there are certainly hospitals that operate with negative margins all over the country. So I don't know a lot about your hospital market here, so I cheated and just went by county. But you can see on this figure, the penalties during the program from 2015 to 2021 for a lot of the hospitals in your area. I know nothing about Longmont United Hospital, but I can say that they have had some pretty steep penalties from CMS. Boulder Community Health, also around 1%. Aurora South, around 0.5%. And then you can see University of Colorado had a close to 1% penalty when that was the cap. So the cap has gone up every year. So Colorado in the first couple of years had pretty high penalties. And then through, I know, a lot of hard work and also some policy change, has gone down quite a bit. And then you can see some over on the far right that have received no penalties in some years or quite low penalties. But this is meaningful money. And actually, frankly, the money being moved by University of Colorado's 0.2% is probably more money than the money in a lot of these other groups, 2 or 3%. So this is a program that moves a lot of money around the country. So did the program work? I mean, that seems reasonable, right? We spent an awful lot of money to administer it. Well, maybe. So this was the first paper that came out about it. And if you look at the blue line, those are the targeted conditions. At the time, it was CHF, acute MI, and pneumonia. And you can see, not so much here, but here, like there's a pretty obvious drop in the middle of that graph, right? Interestingly, that's when the program was announced. And when the penalties were actually implemented in 2012, there has been really no improvement since. And if you keep looking out, there's really been no improvement. I think there's a couple potential explanations for this. One is that we did the easy stuff. So, I mean, I remember when I was an intern in 04, was the first year that we had quality measures for smoking cessation and flu shots. And there was literally a woman with a basket, and she had a sheath of papers. Alice, you probably remember this lady. She would chase you around the hospital and just put the paper in front of you and you'd sign it. And she would go do smoking cessation and give people their shots. And our performance went from, 6% to 100% in a day, right? I mean, that's the kind of thing that you can do when there's an easy thing that you can check the box. And some of that was probably documentation, but some of it was real. I mean, she was much better remembering to order flu shots than I was, right? So that was a systems change. But once you get past that, one possibility is that the reason we haven't improved is because then it's hard. Then it's outpatient care. And do you have what you need? And do you have a doctor? And can you afford your medicines? And do you understand what's happening to you? The other possibility is that hospitals fairly quickly realize that if you're still getting paid for a readmission, there is a threshold to which you should drop those readmissions before the lack of revenue starts to offset the penalty, right? And so if you're a high occupancy hospital, you should avoid readmissions. You'll fill the beds with hips and knees. If you are a low occupancy hospital, don't bother. Keep your beds full. You make a lot more money in admissions than you're going to lose in penalties. It's also possible that this program wasn't that efficacious after all. So we did some work looking at total hospital revisits, which are in the upper left-hand corner. And you can see that, in fact, if anything, they went up. There was a shift from readmissions, which are in the bottom right panel, toward treat and release from the emergency department, and an increase in observation stays. And I know that at some hospitals, there was like a person stationed in the emergency department to fend off unnecessary readmissions, which seems like a good idea, but on the margins may not have been. We did see an increase in mortality, particularly among patients with heart failure, and it was entirely among people who were not readmitted, suggesting that on the margins, we might have made some bad decisions about who needed to come back into the hospital if we were trying to really switch from full readmissions to treat and release in the emergency department, which is what it looked like, at least from a population level, what happened. We also know that this program highly disproportionately penalized safety net and teaching hospitals. So as I showed you, the risk adjustment models may have not quite taken everything they need to into account. And so teaching hospitals, big hospitals, and safety net hospitals were more highly penalized, a pattern which has persisted. And actually, it turns out that all these programs are grossly inequitable. They all rely on the same, chassis, if you will, which is to say that we think that by using claims, we can fairly compare the quality of care that you're delivering to the quality of care that you're delivering. And if you think you can do that, then yeah, run your program and move money around. If you don't think you can do that, and obviously I'm giving with my bias that I don't think you can do that, you end up doing this, which is to say that you are literally taking money from the safety net and giving it to the wealthiest hospitals in all of these programs. Many of them literally work that way. They're zero-sum games. Everyone loses in the HRP, but the other ones are more zero-sum games. And it doesn't matter what you look at. We've looked at physicians, we've looked at end-stage renal disease, we've published home health, nursing homes, the new end-stage renal disease one, the new physician one, they're all the same. They all punish the same people. It's the clinicians and hospitals that are taking care of people who have the highest levels of medical and social complexity. And I don't know any quality improvement program that works by taking people's money away without also offering some sort of solution for improvement. And so have we seen that these programs have made a difference? Oops, sorry, one more slide. So if you also look at how this plays out by race, independent of poverty, these programs also disproportionately penalize high minority caseload clinicians and hospitals, even after accounting for the level of poverty at those places. So we are using these programs to take money away from those hospitals. Now, did they deliver lower quality care? Probably, for the reasons that we've talked about. Is the fix to that to take their money away? Probably not. We don't really have a counterfactual, but I will tell you that these programs have not been associated with much in the way of improvements in mortality or readmissions or any process measures beyond the ones that were easy when we got chased around the hospital to give the flu shots. And they have not had an impact on equity. So you can see here, no change in disparities in readmission rates. The Black patients are in orange and the non-Black patients are in very dark blue, I guess. And you can see overall or in low performing or high performing hospitals, really no change. If anything, a bit of a widening in the disparities in the low performing hospital. So no evidence that this program has has had effects on overall readmission rates or on equity. So, in my opinion, we need a complete rethinking of how we think about quality and value. These programs have not improved outcomes. They've potentially worsened inequities. We're pulling on the wrong levers, and frankly, we're funneling more money into inpatient care when the solution is not in inpatient care. I'm not sure you should get paid for your hospitalization if you don't know to give somebody an aspirin for a heart attack at this point. I have no problem saying that we need to hold people accountable for certain quality measures. But having the hospitals push on all of these things that are fundamentally population-based problems is putting an awful lot of money into the most expensive place to put it. If you want to make housing really expensive, why don't you have the hospital do it, right? This is not the way to get community engaged solutions to make meaningful change in people's lives. And we've been using this hospital lever as a way to improve quality when I don't think that's the problem. Not to take hospitals off the hook, but to say it is a different hook. We should design programs with equity at the center, with input from clinicians, which is lacking on a lot of these, and with recognition of the differences between processes and outcomes. You can be held accountable for processes. I'm not sure that holding people accountable for outcomes that they cannot affect sets up the right incentives. I think it sets up a lot of incentives for bad behavior, and we need to be more thoughtful about centering what is best for the patient and not as what is best to make these programs run. So if we had equity-centered value-based payment, we would prioritize access. No one gets any credit for access. You get credit for your mortality rate. Do you take care of the patients that need you or do you not? Like, what are we doing here? We need to prioritize access and reward it. We need to pay more for outpatient care, and we need to pay more for population health, and we need to pay more for risk reduction among the highest risk groups. If I tell you that you need to get, you're going to be counted, you're going to be paid on the proportion of your patients with a blood pressure less than 135, pick whatever guideline you wish. You're going to go find your patients who were 140 last week and bring them in and give them a cup of tea, and you're going to remeasure their blood pressure, and they're going to be fine. If I tell you you need to bring your average blood pressure down, or that you're going to get paid for your delta blood pressure, who do you go find? Your sickest patients. That's who needs you. And we've set up all these programs to reward beating the program and not helping the patient. That's more complicated. It's harder to measure finding the average or the highest risk, but it's worth it. And in this day and age, I shouldn't do that we can put people on the moon because that's old news, but like we can do a lot of stuff. We should be able to do this better. We have to come up with programs that provide resources to historically marginalized groups rather than take them away. And we have to facilitate connections to community-based resources and start putting the resources that we're funneling into hospitals and consultants into community-based resources to take care of patients. Our hospital paid McKinsey a lot of money to tell us how to succeed at those programs, and that is not a good use of healthcare dollars. No offense to McKinsey, I'm sure they're very smart. We need to also leverage clinician and patient engagement instead of thwarting it. A lot of these programs have come out pretty heavy on the cost side. Do you want to sign up for a program where you have to cut costs for your patients? I do not. And as a patient, I definitely don't want to be told that I'm in a program where you're trying to cut costs. Don't cut my costs, like give me what I need. Would you sign up for something that made you healthier? Probably. Would you as a doctor want to do more for your patients when you know we can do more for our patients in a better system? Yes, you would. And we need to think about programs and we design them with some sort of behavioral economics lens to make that feasible. Okay, so final element, the trickiest, social and economic policies. So we know that some communities and groups have much more resource than others. And I've talked about the structural reasons why that's the case. But health is a public good. It's not just COVID. I think we all knew that health was a public good when we're thinking about COVID, but it's people's ability to reach their full potential. We are collectively better when we are collectively healthy. You can take the moral argument, you can take the economic argument. They actually both get you to the same place. And we need to think about it as a public good that we have to invest in the same way as we would invest in a different type of public good, that it's a collective need. It's not a competitive need. As I've mentioned, the problems that we see aren't accidents. Structural problems won't go away without structural solutions. And that includes naming the effect of racism and historic disinvestment on a lot of these problems that we see. And we need to intentionally change each of these elements: access, economic opportunity. We need to train clinicians from historically excluded groups, and that goes not just for physicians, but for nurses and pharmacists and community health workers and whoever, right, to make communities healthier, both to get health into the community and also to bring the community to health, right? We need people with different lived experiences to make us better as clinicians, and we also need people with different lived experiences to connect with communities to make the communities healthier. And that includes both historically excluded groups, including people with minority backgrounds or disabilities, as well as clinicians from rural areas who have been progressively underrepresented in training pipelines for just about every type of healthcare profession. So you've probably all seen something like this about equality versus equity. You have three people standing trying to watch a baseball game, and one person is too short to see over the fence. So if you give them more boxes, then they can see over the fence. I think that's lovely. I fully support more boxes for people who are short. I don't actually love this picture because I think it sends the message that there is something different about that person who needs the extra boxes, which is fine. Again, more boxes for people who are short. But this one, I think, more accurately represents the problem. There are people who are born standing in holes with bigger fences in front of them. So you have to do something different to change that. And you can temporarily prop things up with boxes. There's nothing different about these people. They happen to be blue and red and yellow, but there's nothing like structurally different about them. They were put in a different starting position with a different set of obstacles in front of them. And part of our responsibility is to do something about that. And it can include the boxes. We should do the boxes, but we should also get rid of the fence and get rid of the hole. And if you don't do that, you're spending an awful lot of money stacking boxes, which again, we should do it, but let's not stop with the boxes. So in summary, I'm like out of breath, this altitude is killing me. So health policy is a crucial tool to improve health outcomes and reduce health inequities. And what was structurally done needs to be structurally undone. I will grant you that the time frame is long, but the opportunity for impact is large. And if we work on this collectively, and if we can be a voice for this collectively, we can shift the Titanic with time. So thank you all very much. Thank you to all of my colleagues. And I look forward to, I think I left some time for discussion. So I'd love to hear your thoughts. Thank you.
Take some questions. Larry?
Larry's going to give me the softball question.
So two questions. One is, when are you moving back to Colorado? Second question is, there's obviously a lot of problems to overcome. And, you know, I think three buckets just listening to your talk is: one, we don't know what we're doing. The second is that we have a broken political system that can't get done what needs to be done.
Yep.
And the third is that we don't actually believe in equity as a society. And I'm wondering which you think is dominant.
Like I said, the softball question. Well, that's a good question. So I think 2 and 3 go together, right? So we've created a political system based on inequity. And the people that are part of that political system and the way that it's set up does not reward moving toward equity. It rewards getting what you can get. So those two things are linked, and they're pretty tough, and they're not getting better. They're clearly getting worse. I think the disruption during COVID has made clear, at least to me, that a big part of all this is trust and stability. And it's been interesting participating in some various strategic planning things. It's like they used to be all about innovation and like, what can we do fast? And now it's all like, how do we get trust? Like, how do we make people feel safe? How do we build connections, right? A lot of that has been pretty irreparably torn apart. And so the question is, can we put that back together in a way that's sort of collective? I don't know. Healthcare is suffering from the same issues as education. All the stupid fights about who's in control of what bit of education. And it's just ridiculous, right? It's completely political. So I don't know what the solution is to that, but I think those two are very much linked together. The we don't know what to do part is the most fixable, because we kind of do know what to do. I don't know that we know how to do it, but like, you know, race theory, race study is not new. There's been people who've been working on this stuff for decades. We haven't been listening. Community engaged research isn't new. There's been people who've been working on that for decades. We haven't been listening, right? The power structures have all been in the wrong place, but we kind of do know what we need to do to some degree. It's really the second and third that are the more major problem. And I think the opportunity around things like implementation research is actually to figure out how to translate what we need to do into messaging that's not so political. And maybe we can kind of end around on 2 and 3 if we can get a little bit better at communicating around 1. Maybe.
Scott?
Fantastic talk. So let me ask you, and this, not an easy answer here again, but I'd like to hear your thoughts on it. So you showed that our initial slide, we're spending more money than any other society, but getting nowhere on it. And then, so let's say we just insure everyone, we're much better at treating, or we're much more focused on treating than we ever are on presenting. So on the policy side of this, rather than just moving to, okay, now we've expanded Medicaid, Medicare, and everyone has access to TAVR, for example. Do you then have to policy regulate that? Oh, actually, this money is now going to go more towards, the prevention aspect of it to move that line at the same time. And or is it just too many things to focus on once, and you have to get Medicaid expansion first without the policy portions?
That's a very insightful question. So, I think the big success of the ACA was access. I mean, we've moved to the lowest uninsurance rate we've ever had. And so the access problem is not solved, but how we get there is somewhat solved. So that's less of I don't know that you need like the higher cortex thinking around how we get to better access. Like those other states need to expand Medicaid, and they're getting, more and more carrots to do so. And I think we will eventually get there. But the second part of your question then is, what do you do about that to actually shift toward prevention is much harder. I was actually saying earlier to someone that a colleague had said like 10 years ago, why don't you just pay more for stuff you want people to do more of and less for stuff you don't want them to do? Like that would solve the problem. Stop paying so much people should get their TAVRs if they need them, but pay more for prevention. People will go do it. People are, we're working in an economy. This is capitalism. People know how to get their money. So there are some shifts that you could make to try to incent that. The investment that we really haven't made is in the systems of care. And I don't mean systems like Colorado or BJC who are, buying up the world. It's more in the idea that like your health you should be part of something to get your health taken care of. And it should be sort of chronic relationships and all that. That's really fallen off with sort of the move, with more we can do as an inpatient. So you don't really, hospitalists, for example, right? I'm all for hospitalists. They clearly do a great job at inpatient care, but the downside is that you don't get your outpatient physician that knows you. So the systems don't really exist to invest in prevention in the same way. The money is more and more concentrated in the inpatient and the doing things. So we could change how we pay. There's a committee that does that. It's extremely difficult to change who gets paid for what. The population health models that Medicare has come up with, accountable care organizations particularly, are supposed to do that. They're supposed to pay you for keeping people out of the hospital. There has been some success. Physician-led organizations clearly do better than hospital-led ones for pretty obvious reasons. Physician-led organizations don't get paid as much when you're hospitalized. So they've been more aggressive about keeping people out of the hospital. So I think probably the best policy evidence we have right now is in accountable care organizations, but leaning more on the physician side and putting more resources into keeping people out of the hospital and innovating there.
But following up on that, don't the ACAs, so aren't they so biased based on what population it is that you're covering? So if you're covering a higher risk, more rural, more diverse population, isn't it going to be harder to maintain a financial model?
So that is a great question. I'm so glad you asked that. I did actually not even plant that. So ACOs were, when they started, the one, to me, financial model that made sense. So ACOs were judged against their own historical spending. So the targets were very different. So if you were a high cost ACO, your spending targets were higher, but you just had to get better and you got rewarded for getting better. So it is the only program that wasn't on that list. It actually, the folks that did best in the first 2 years of the ACO program were the high disabled, high minority, high poverty ACOs, because they had the highest targets and frankly, the most room to move. I mean, the people who needed the most and could benefit the most from intervention. The problem was that then all of the low cost ACOs who had been told they were so excellent and they weren't winning, got angry. And then they changed the program so that now there's these like blended targets, and now it's as unfair as the other ones. But it actually has a great policy lesson, just like, why are we even trying to compare groups to each other, right? Like if you want to take a school in a really rough part of town and take the school's money away because their first graders aren't reading at grade level and give it to the school in the suburbs where the kids have all been tutored since they were 6 months old, like that doesn't make any sense. And that's what these programs have done. But could you tell both of those groups to improve? Absolutely. And if the group that's already doing great doesn't improve that much, okay, I mean, that's not where your responsibility is, I think, as sort of a, governmental organization. So in my mind, the way that ACOs were initially set up was actually a great solution. Just get better, and we'll reward you for getting better. But don't even pretend that you can fairly compare groups. I think that would be a much more equitable way to do things. So you should run that. So it's a great question.
We'll wait and see if we have any questions from online, but I want to ask you sort of a micro question. One of your slides was really interesting. It showed the penalties that were assessed to all of Colorado hospitals. And I noticed on the right-hand side of the graph was our county hospital, which I think people might take great pride in, and several smaller, well-insured hospitals in nicer parts of town. How do you get to the right side of that graph? Why are those two hospital systems in that same area?
I mean, you have low readmission rates. The other way that you get there is by documenting how sick your patients are. So, one is that readmission rates really are much lower in the sort of wealthiest, healthiest hospitals. But one way that you get farther down that list, which is interesting, if you compare the resource of the hospital, is by coding. So, I had a co-fellow who went to Montefiore after fellowship. And I was at the Brigham after fellowship, and we were comparing notes at, I don't know, out somewhere. And I was talking about we had to bill ourselves. I don't know if you guys bill for yourselves. They don't even let us do that at WashU. They just don't even let us touch the billing. But we had to bill ourselves, and you would get I would at least get 6 emails a day that were like, we noticed that your patient's creatinine was 1.4. Have you considered coding, renal insufficiency, or it's called at the time. I was like, oh shoot, I go back in and I bill. I was a terrible biller. Yeah, so right. So you get what I'm talking about, right? So I had very well captured comorbidities. I mean, someone was chasing me around like the woman with the basket. And I was comparing notes with my friend who was at Montefiore, and they had paper billing on the front of the charts, and she would just check QMI. And that's what she's getting paid for. And she later realized when she moved to Cornell that they were getting no credit for how sick their patients were because they were coding no comorbidities because they had no billing or coding, I guess. People chasing them around. We have a building of coding people. They don't, like I said, they don't trust us to code. There are people that sit in a building on the highway, maybe at home now, and they code every single thing they find. And so if you're risk adjusting and it's on that list, it is quite clear that 2 hospitals, one that is more resourced and one that is less, it is a difference both of actual sickness of the patients and a big difference in coding. And then also quality. There are places that have done very, very cool things to reduce readmission. So I don't want to take anything away from the folks that have really dug in and done it. Yes. Great.
Right. So I'll just, if I can ask.
Sure. I got no place to go.
I can just scout it. So I guess I have a question about how people argue against what you're arguing, right? So obviously there's somewhere in America they're having an opposite talk.
They're all wrong.
Yeah, and I agree. But what should we expect? How do we? I think about our trainees and the people that are going to come along and try to take this fight, from take the mantle from you and take it on. What should they expect in terms of why we can't make these changes? What should they expect in terms of the things they're going to have to mobilize to fight this fight?
So I have found that the most successful way to advocate for these changes is apolitically. I mean, you can have the political conversation, but it goes about as well with my, crazy family members as it would with someone in Congress. It just doesn't get you anywhere, right? But the apolitical discussion around what patients need, if you actually look at it, the solutions to both sort of code word for poor minorities, sort of urban poverty, and code word for poor white people, rural poverty, they need the same thing, right? You need resources in your community to help you stay healthy. And so it's shifting the conversation toward how can we make policy that gets resources to communities to help them stay healthy, and then leaves it to them to figure out what they need, actually kind of can speak to people on either political side. But the political discussion doesn't work. The other thing that has been tricky with, COVID is that you need major legislation to change this stuff. It's written in law. And so even if everyone at CMS thinks that there's something wrong with these programs, and I will tell you, people at CMS are kind of sick of most of these programs, they're ready for the refresh. They can't do it. Congress has to. And there's been too much going on with the chaos of the transition to the Trump administration, that then there was just so much shifting, much more than usual for a political turnover. And then obviously COVID, there just hasn't been the opportunity for people to sit down and make change. So some of it is that I think we will hopefully have opportunity to make change in the next couple of years. CMS and CMMI have signaled they would like to do that, and there have been some legislators that are interested. So part of it is that the political wins have been even made more difficult by, the global pandemic. So fingers crossed that in the next couple of years we do see some movement. There's a question back there too.
It's working again.
Yeah, I mean, that was a really excellent talk. I'm curious, I wonder if some of the reason that, a lot of these incentives and programs are targeted towards hospitals is because it's like, this is a place where we can ask them to do things and get results back.
Yep.
Part of what you're talking about is kind of implementing solutions within the community that are lower cost, but then where would your community center be? Like what, would you then be accessing like public health departments and shifting like massive resources to them and then relying on them to say kind of, hey, Pueblo Department of Public Health, like, please make this happen?
Right.
What happens with that?
Yeah, that's a great question. So it's sort of the problem of like the transition costs are very high. You would not design the system as it currently is, but it is what it is. So you'd have to come up with a transition plan. And the money is never going to go away from hospitals. That's where the power is. And they've now sucked up all the outpatient practices and everything too. So it's really not going away. So the hospitals initially were put in these programs because they were the only entities that could bear risk. And so that was where you could start. They were the only ones that could do it. I don't think you want to create the same programs to make the Pueblo Department of Health bear a bunch of risk. That's unrealistic. I do think they could probably use some investment. If they look anything like our public health agencies, they're sort of grossly understaffed and undersupported. So it requires something different. It's not a quick fix. It is really not a quick fix, but I do think that you can lean on the hospitals to shift things toward the outpatient side, which they now own, and you can try to put more money into public health and into the communities without putting it through the hospital first. But this is not like a 6-month fix. This is 10 years of work.
Great. I think we're right at 1 o'clock. So Dr. Joynt Maddox, thank you very much.
Thank you.